Good morning and welcome to Madison Grand Rounds. I'm not losing my voice. I've lost my voice, but hopefully it will enable me to do justice to introducing our dream speaker today. Dr. Paul Palevsky is a graduate of Northwestern, where he was in the honors program that combined undergraduate and medical education, graduating with AOA honors before undertaking his internship and residency at the University of Pennsylvania, where he then stayed on for fellowship in nephrology. He served as a research associate in medicine at Penn until joining the faculty as an assistant professor of medicine at the University of Pittsburgh School of Medicine, where he stayed throughout his illustrious career, rising to the position of professor of medicine. He is renowned, and this is Amber Hertz-Tang's selection for her dream speaker, renowned in his work in really large clinical trials in the areas of nephrology and even hypertension and diabetes overlap, and has 87 original publications, many in high-impact journals such as the New England Journal of Medicine. He's also provided really an astounding 137 invited reviews, editorials, and book chapters. He's currently funded as a multiple PI in 3 large grants, 2 with the NIH and 1 with the VA cooperative study, with an overall budget of $23 million. He's an active clinician serving at the VA Pittsburgh Healthcare System, both as in consultation, in dialysis and renal clinic weekly. He's been an avid educator at all levels. I made note that he's been a mentor to postdoctoral fellows easily 28 times. He's also been a mentor to faculty and others. He's a good citizen overall, providing grant reviews for the VA and the NIH, National Kidney Foundation, and is active in editorial work. I counted 11 positions. Most currently, he's the deputy editor of the Journal of the American Society of Nephrology, and last night I got to learn about how busy an effort that is. He's also been an active citizen, providing consultation and input to the VA, the NIDDK, and other professional organizations, including the Kidney Care Partners, the National Kidney Foundation, and the National Quality Forum. He's won a number of awards over the years, including the Educational Ambassador Award from the International Society of Nephrology, the Hayes Davis Service Award from the Renal Network, the Lazarus Distinguished Award from the National Kidney Foundation, and the ESRD Patient Safety Award from the Renal Physicians Association. He's given invited lectureships throughout the country and throughout the world, including 15 named visiting professorships. He's never before, however, been a dream speaker. And with that, it's really my pleasure to introduce Dr. Palevsky as he provides grand rounds entitled Contrast-Associated Acute Kidney Injury. Does it exist? Can we prevent it? Please join me in welcoming Dr. Palevsky.
Well, thank you for that kind invitation. Just necessary disclosures, none of which really reflect on what I'm going to be talking about today. So let me begin with a clinical case. 63-year-old woman with a history of diabetes, hypertension, coronary artery disease, chronic kidney disease, is evaluated for new onset or recurrent onset of exertional chest pain and dyspnea. She has serum creatinine of 1.7 corresponding to an EGFR of 32 with a urine albumin excretion that's elevated at 932 micrograms per milligram creatinine. She has a history of a prior MI and previously had a drug-eluting stent placed for a mid-LAD stenosis. She has a history of heart failure and has a modestly decreased ejection fraction. Over the past 3 weeks, she's developed new exertional chest pain with progressively lesser degrees of exertion. She had a nuclear scan that was positive for ischemia, and she was referred for coronary angiography. Her medications include furosemide, lisinopril, amlodipine, isosorbide dinitrate, fenofibrate, and a baby aspirin. The angiography is performed as an outpatient. She's found to have an occlusion, a 90% occlusion in her proximal circ, which is stented. 4 days after the procedure, she complains of worsening dyspnea, is found to have pulmonary vascular congestion on exam, increased edema in her lower extremities. There are no embolic skin lesions. Her serum creatinine is now 2.6, progressively rises over the next 3 days, peaks at 5.6 before beginning to recover. 2 weeks after this episode, her serum creatinine is down to 2.1, but still above her prior baseline. So this is a classic case of contrast-associated acute kidney injury. Patient who develops a sudden onset of worsening kidney function following exposure to dye without evidence of another etiology, although it's always impossible to rule out subclinical atheroembolic disease after an angiographic procedure. But we would call this contrast-associated disease. This is a common occurrence, we believe. There are lots of angiographic procedures done annually. A decade ago, data said that there were about 4.5 million coronary and non-coronary angiograms performed every year. It's estimated that this results in between 100 and 125,000 cases of AKI. Economic analyses have said that the cost is about $11,000 per case. So if you do the math, that works out to between $1 and $1.5 billion per year of cost from what should be a preventable etiology of acute kidney injury. Although I think every nephrologist will tell you contrast-associated AKI exists, there's actually been a controversy over the past decade, driven in the radiology literature about whether contrast-associated AKI after CT scans in particular is an actual entity. And this is driven by data such as this from Dr. McDonald at the Mayo Clinic, looking at patients getting CT scans and comparing with and without contrast and trying to ascertain what the true rate of AKI is. So in this study, this is a propensity-matched comparison of patients who received CTs with contrast to patients who had CT scans without contrast. And you can see over 10,000 patients in each group, fairly well matched by age, although the non-contrast group was a little bit older, similar sex, slightly higher creatinine, not statistically significant in the non-contrast group, slightly higher rate of CKD in the non-contrast group, and no significantly different rate of AKI. In fact, the actual rate of AKI in the non-contrast group, both defined by small changes in serum creatinine or dialysis requiring, was slightly higher in the patients who didn't receive contrast. But there's a problem with studies like this. Why do patients get CT scans without contrast? Often it's because we have a concern that there's greater risk. There's also an issue of ascertainment of AKI afterwards. If you're not worried about the development of AKI, you're not going to be following the serum creatinine concentration. There are also some issues in how the propensity scores are developed here. Most of the factors going into the propensity score are factors for risk of AKI, and notably not included in the propensity score is a key factor in who gets contrast and doesn't get contrast, allergy. So with all of that, there's the risk that there's residual confounding and that the finding here may not be completely reflective. Now, they've gone on and looked at the risk of AKI in the Mayo Clinic series, stratified by level of kidney function, and found no difference based on level of GFR. But if you go a little bit east to Ann Arbor, the group at Michigan has looked at this and said that although they don't find a risk in patients with a serum creatinine of less than 1.5, they actually do see an increased risk of AKI following contrast exposure when patients have elevated serum creatinines, and they've also analyzed this based on eGFR and found the inflection point to be an eGFR of around 45. In a larger study, and this is a study from nephrologists looking at administrative data from the National Inpatient Hospital Survey. This is from Glenn Chertow's group at Stanford. They looked at patients who either did or didn't get exposed to radiocontrast media. And they also found that exposure to radiocontrast was not in this large database associated with an increased risk. Here you can see that in fact in the adjusted model, the risk of AKI associated with contrast exposure was 0.93. And when they stratified by comorbidities, what you can see is that only in the patients with the highest level of comorbidity was contrast exposure associated with an increased risk. But they then state in their discussion, even sophisticated analyses may fail to detect the full effect of patient selection on their results, and in that case may erroneously conclude that there's no real risk to patients, even those previously believed to be high risk, such as patients with CKD or diabetes. For this reason, we must interpret this study and similar studies with caution, carefully weighing the benefit of contrast-enhanced studies with risk, likely low but likely not zero, of radiocontrast administration on the kidney. So certainly radiocontrast is not nephroprotective, as you might conclude from their data. And I think that experience clearly states that there is risk associated with contrast exposure. But one of the key points that we have to remember is that we shouldn't avoid doing appropriate, the key word here is appropriate, contrast studies on patients who are at high risk because of our fear of AKI from the contrast. There are data that patients with CKD who show up in the emergency room with a classic story for an MI and ST elevation on EKG are less likely to end up in the cath lab and less likely to have PCI than a patient without CKD. And if you show up, and if you are one of those patients with CKD who shows up and doesn't get what would be considered the appropriate intervention, you are more likely to die. So we are actually under-treating patients because of fear of contrast-associated AKI, a syndrome that Dr. Chertow has termed renalism. Now, are there direct comparisons to show us that contrast exposure is nephrotoxic? And the answer is no, there haven't been good RCTs. There's some data looking at iodinated contrast versus angiography using CO2 as the contrast agent that shows that iodinated contrast is associated with greater risk. You probably can't see it from where you're sitting, But this is overall, and down here are the patients with CKD. The point estimate of the hazard is about a 50% greater risk of AKI associated with iodinated contrast exposure, and although it doesn't hit statistical significance in the subgroup of patients with CKD, that's probably attributable to the small numbers of patients. There is a randomized controlled trial currently underway looking at patients, randomizing patients to CT with contrast and CT scan without contrast in patients who need follow-up for endovascular aneurysm repair, so stenting of AAA, comparing non-contrast plus ultrasound to contrast-enhanced studies, and it will be very interesting to see the results of that study when it's completed. So with my conclusion is that contrast-associated AKI still is a real entity, although we probably do overestimate the risks. So what are the risks for contrast-associated AKI? And I break these down into patient-associated risks, including underlying kidney disease, diabetes, proteinuria, volume depletion, reduced cardiac output, and concomitant nephrotoxin exposure, particularly nonsteroidals. And procedure-related factors, including the dose of contrast, and one of the things we've observed is that our angiographic colleagues, both in cardiology and in radiology, are using smaller and smaller volumes of contrast in order to do procedures, do diagnostic studies. Multiple procedures within 72 hours is associated with an increased risk. Intraarterial as compared to intravenous administration, and the actual type of contrast. Now, risk prediction scores can be developed. There have been several in cardiology that have been developed. I don't find these particularly useful. This is one of them. You can see the key factors here include level of kidney function, use of an intra-aortic balloon pump, emergent procedures, diabetes, heart failure, hypertension, peripheral vascular disease. Contrast volume, so of course this is something you can't use prospectively because you don't know how much volume is going to be given. The scores are well calibrated, so here you can see how the risk increases with higher scores. But the problem is that most patients are low risk. So when you actually look at the distribution of patients developing AKI, more patients who are low risk develop AKI than patients who are high risk. So that's why a score such as this really is not all that helpful at the bedside. A word about the pathophysiology. We don't really understand the pathophysiology. As you can see from this rather simple cartoon describing the contrast of contrast-associated AKI. Let me break this down into a slightly simpler view. So radiocontrast administration is associated with renal vasoconstriction. It's associated with changes in intrarenal blood flow, thought to be due to viscosity issues, and the osmotic load from the dye changes tubular transport, the osmotic load, increasing oxygen demand. All of these factors contribute to a degree of medullary hypoxia. The contrast, particularly the ionic forms, plus medullary hypoxia associated with the generation of reactive species. There's also direct cytotoxicity, and all of these combine together to the risk of AKI. One of the things that you should be able to readily see from this is that other than not giving contrast in the first place. There is no one step in this process that will eliminate all the risk. So there have been efforts at trying to make less toxic contrast agents, but we've had multiple other approaches trying to mitigate the risk of contrast-associated AKI. So strategies include the selection of contrast agent, volume administration, pharmacologic therapy, more recently, remote ischemic preconditioning, the use of prophylactic hemodialysis and hemofiltration, and I will show you the data to disabuse you of believing that that's of any benefit, and avoidance of concomitant nephrotoxins. So let me start by saying a few words about contrast agent. So this is to remind you that not all contrast agents are created equally. In the 1970s, we had the use of what have been termed the high osmolality agents. These are all ionic triiodinated derivatives of benzoic acid. These were then replaced starting in the 1980s with what are referred to as low osmolality agents. They're not really low osmolality. They have an osmolality of between 500 and 800, so they're actually hypertonic to plasma. And these are either ionic dimers or non-ionic monomers of triiodobenzoic acid. And then in the late 80s, we saw the introduction of the isoosmolar agent iodixinol, which is a non-ionic dimer. Now, as you move from the monomer to the dimer, you have increasing viscosity of the agents, and it has been suggested that the viscosity may be a separate problem. Studies looking at the relative nephrotoxicity of the older high osmolality to the low osmolality agents suggested that there was less nephrotoxicity with the low osmolality agents, and this was most notable in patients who had prior renal insufficiency, where the number needed to treat was 8. We have basically stopped using high osmolality agents in the United States and other Western countries, but low osmolality agents are widely used. Much of the interest in the isoosmolar agent was really piqued by this study in the New England Journal of Medicine, published 15 years ago, comparing iohexol to iodixinol, showing this remarkable reduction in the risk of AKI associated with iodixinol use. And that then triggered a series of studies and multiple meta-analyses of those studies looking at the relative risk of the isoosmolar to the low osmolar agents. This is one of the better of the meta-analyses, which found an overall lower risk with iodixinol, but a high degree of heterogeneity. And they were able to analyze that heterogeneity away when they looked at the studies that compared iodixinol to iohexol, showing a benefit to the iodixinol, as compared to iodixinol versus all the other agents where they didn't see a benefit. So the question is it that iodixinol is better than low osmolar agents, or is it iohexol is an outlier among the low osmolar agents and associated with a higher risk profile? Since there are so many options, my personal view is that we should not even worry about it, and we can use other agents besides iohexol, although the folks from GE Healthcare probably don't like that suggestion. Let me move on to the things that we can do as the bedside clinicians to try to decrease the risk, since we usually don't have the choice of what contrast agent is going to be provided. or used in the study. So volume administration has been the mainstay of preventative therapies, and the questions have been oral versus IV, isotonic versus hypotonic, and more recently, what anion should be in the solution. Should it be chloride or should it be bicarbonate? So the question of oral versus IV fluid, I had thought that we would never see a study after this one looking at it. This is a study that was done by Hara Prasad Trivedi at the University of Missouri, where he compared high-risk patients undergoing angiographic procedures, either getting oral fluids or isotonic saline. The study was stopped at the interim analysis by the Data and Safety Monitoring Board because there was almost a tenfold higher rate of AKI in the oral fluid group 2. So I didn't think anyone would ever try this again, but in fact, last year there was a study published in The Lancet looking at the exact same question, although in a relatively lower risk population, the rate of AKI was about 2.4%, I believe. This was designed as a non-inferiority study with an 80% non-inferiority bound, and they found that oral fluid was non-inferior. There are a number of issues in this. The sample size is very small, and as I said, this was a relatively low-risk population, at least in retrospect. If you were to do a non-inferiority study of placebo versus aspirin for the primary prevention of MI in 25-year-old men, you would find that there is no benefit to aspirin. You have to study an appropriately high-risk patient in order to demonstrate whether there's a benefit or not. So I think they focused on the wrong population. There are studies that have looked at saline versus isotonic saline. This was a low-risk population with a large sample size done in Germany that demonstrated better outcomes with isotonic as compared to half isotonic saline. It did not reach statistical significance for mortality, and they saw no differences in vascular complications. One of the studies that has shown that more fluid is better than less fluid is a study called the Poseidon trial. So this was a relatively small, less than 400 patient study done at a single center where patients were randomized to either receive a standardized volume administration, 3 milliliters per kilogram of saline for 1 hour pre-procedure and 1.5 milliliters per kilogram per hour over 4 hours post-procedure, or to receive fluids based on LVEDP during the cath. So the same 3 milliliter per kilogram over 1 hour pre-procedure. But then if the LVEDP was low, a higher rate of volume administration, and if it was greater than 18, the same 1.5 milliliters per kilogram per hour as in the control arm. As expected, the patients getting the LVEDP guided fluid administration had much more fluid delivered to them. A key point is they did not develop pulmonary edema in either arm, and what was seen was that the LVEDP guided fluid administration was associated with a significantly lower rate of AKI using multiple different definitions of AKI than the control arm. So takeaways from the Poseidon trial: if your patient is volume depleted, give more fluid if they have a low LVEDP, and that it is safe And I should point out, all of the patients in this study had an EF of less than 45%. So it is safe to give fluids to patients who have heart failure, even if they have an elevated LVEDP, so long as they're not in clinically decompensated heart failure at the time of the procedure. The biggest issue over the course of the past decade and a half has been this question of bicarb versus saline, triggered by this study published in JAMA in 2004 by Merton and colleagues that looked at fluid administration with saline to bicarbonate, showing this remarkable reduction, 1.7% of the patients in the bicarb arm versus 13.6% in the saline arm. Now, this study was stopped at the midpoint by the safety monitor because of overwhelming efficacy. Now, the p-value was just marginally less than 0.5%, and good statistical management of a study where you're looking at an efficacy benefit says that you're not going to stop at that level of the p-value. In fact, this study had a fragility index of 1. A fragility index says that if the next patient enrolled in the bicarbonate arm had developed AKI, it would no longer be a statistically significant study. Nevertheless, it was published in a high-profile journal, received a lot of publicity. In fact, the senior author took out a patent on bicarb for the prevention of AKI. An interesting issue to deal with. And it triggered a cottage industry of small trials looking at bicarbonate versus saline. This is a meta-analysis that was published in 2016. This doesn't even have all of the studies that had been done using their quality control. They excluded a substantial number of the published studies, but they observed that at least at this point, the point estimate suggested a benefit for bicarbonate, but they then did what's known as a sequential trial analysis interpretation, where they looked at each trial sequentially as if they were interim analyses in a single large clinical trial to see whether it would meet the stopping rule, either for efficacy or for futility, and the answer was no. So their conclusion was that there was insufficient data. So it was in that morass that my colleague Steve Weisford and I waded in with the PRESERVE trial. The PRESERVE trial was a large, modestly pragmatic, randomized controlled trial looking at bicarbonate versus saline and N-Acetylcysteine versus placebo, and we'll talk about the N-Acetylcysteine side in a bit, in a high-risk population of patients undergoing coronary, non-coronary angiography. Our target was to enroll 7,680 patients. We were actually stopped by the study sponsor after enrollment of 5,177 patients. There were a number of patients who were excluded from the pre-specified modified intention to treat analysis because their angiographic procedures were canceled and they didn't receive any of the study interventions. So there were 4,993 patients in the analytic cohort, randomized in 2x2 factorial design to either saline, bicarbonate, or either N-Acetylcysteine and placebo. So we end up with 4 potential treatment combinations: bicarb plus NAC, bicarb and placebo, saline plus NAC, saline and placebo. We analyzed to determine whether there was an interaction. There was no interaction between the treatments, so we could analyze this at the margins, looking at the two interventions separately. So the first analysis is the comparison of bicarbonate versus saline, looking at 2,511 patients who received bicarb, 2,482 who received saline, with or without NAC in each group. Comment about the fluid administration. We had a semi-protocolized approach here. So bicarb was 1.3% sodium bicarbonate or 0.9% sodium chloride. We actually had a manufacturer who provided us with the bicarb, so we didn't need to have the local pharmacy reconstituting this by injecting bicarb into bags of sterile water. Pre-procedure, patients were to receive 1 to 3 milliliters per kilogram of fluid over 1 to 12 hours for a total infusion of 3 to 12 milliliters per kilogram. This sounds very confusing. It really was much simpler. If the patient was an outpatient, the recommended infusion was 3 milliliters per kilogram over 1 hour. If they were an inpatient, they should get 1 milliliter per kilogram over 6 to 12 hours. During the procedure, 1 to 1.5 milliliters per kilogram per hour. And then post-procedure, 1 to 3 milliliters per kilogram per hour over 2 to 12 hours. Total infusion of 6 to 12. Again, stratified by inpatient or outpatient status. So the recommended regimen for an outpatient was 1.5 milliliters per kilogram for 4 hours. For patients who, as we started seeing more and more radial approaches where the cardiologists were trying to get them out of the procedure area within about 2 hours after the procedure, not needing to wait as long to pull the sheath, we went up to 3 milliliters per kilogram over 2 hours. For the inpatients, 1 milliliter per kilogram per hour for 6 to 12 hours. We capped all of the infusions based on a maximal weight of 125 kilograms. So what did we see? I should point out the groups were very well matched in terms of all characteristics, both procedural and demographic. What did we find? No benefit to bicarb. Our primary endpoint was a combination of death, need for dialysis, or persistent decline in kidney function at 90 days. The odds ratio favoring bicarbonate was 0.93, although the lower bound was 0.72, which would actually satisfy a non-inferiority test for sodium chloride. Looking at our secondary endpoints, including contrast-associated AKI, which actually had a rate that was slightly higher in the bicarb group, and all the other pre-specified secondary outcomes, there were no differences. And this is pre-specified subgroup analyses. This side for the primary endpoint, this side showing the development of AKI. The only difference that we saw in subgroup analysis was actually a better outcome associated with saline in a subgroup of patients having non-coronary angiography. We interpret this with considerable caution since we're not adjusting for multiple comparisons here, and there were very few events in this population. So we actually don't think that that's a statistically meaningful outcome. But it favored saline over bicarb. So at the moment, I would say that the standard of care should remain the use of isotonic saline administered pre- and post-procedure in high-risk patients. What about pharmacologic therapies? Multiple therapies have been tried: diuretics, antioxidants, statins, vasodilators, adenosine chelators, iron chelators. I'm not going to go through all of those. There's lots of data on diuretics. Early studies, so from Rick Solomon at the University of Vermont, classic study from 25 years ago in the New England Journal of Medicine, looking at saline, saline plus mannitol, and saline plus furosemide that showed, in fact, harm with mannitol or furosemide. This study was then criticized that there wasn't careful attention to making sure patients didn't become volume depleted with the diuretics. So in a study that was done with forced euvolemic diuresis with attention to try to keep patients from getting volume depleted. Again, the diuretics were associated with a higher rate of AKI, certainly no benefit. So is it that diuretics are harmful? Data would suggest that's not the case. So if you have a system where you match the urine output and the IV fluid administration, basically by putting a flow meter on a Foley catheter and integrating that with the infusion pump, you can demonstrate that there's a benefit. So patients are given a bolus of saline, then given a bolus of furosemide with this matched infusion of saline to urine output, and they go to the cath lab when the urine output exceeds 300 milliliters an hour. And what's been demonstrated in several studies now is a protective effect with a lower rate of AKI. Here's a meta-analysis of a number of the studies showing this benefit. However, I would point out that patients who have a forced saline diuresis in this setting, what they put out in the urine resembles half normal saline. What they're getting is normal saline, so they are likely in positive sodium balance and actually being volume expanded over the course of time, despite the fact that they had received a diuretic. So I don't think there's evidence that the diuretic in and of itself is harmful. What about N-Acetylcysteine? Here, the interest was piqued by this study published in the New England Journal in 2000. This was a study of, I believe, 86 patients undergoing CT scans who received 600 milligrams twice a day of N-Acetylcysteine on the day before and the day of the procedure. And you can see the marked reduction in the rate of AKI defined by a 0.5 milligram per deciliter increase in serum creatinine. And in fact, if you look at the serum creatinine at 48 hours, in the N-Acetylcysteine arm, there was a reduction in serum creatinine concentration. Again, this provoked a cottage industry of predominantly small single-center studies. Of the studies here, there's only one study, the ACT trial from Brazil, that had more than several hundred patients. That was a study with 2,306 patients. That was an entirely negative study, but in this meta-analysis from 2016, the odds ratio, the point estimate favored N-Acetylcysteine of 0.7, and it was a statistically significant benefit. So what did we see in the PRESERVE trial? So here we had 2495 patients getting N-Acetylcysteine and 2498 getting placebo. We used a slightly different approach to N-Acetylcysteine administration. We gave patients 1,200 milligrams PO 1 hour pre-procedure, another 1,200 milligrams PO 1 hour post-procedure, and continued the N-Acetylcysteine as a BID dosing, 1,200 milligrams twice daily for an additional 4 days, for a total of 5 days of therapy. And what we saw was no benefit whatsoever. 4.6 versus 4.5% rates of the primary endpoint, 9.1 versus 8.7% rates of contrast-associated AKI, at 3 to 5 days after the procedure, and no difference in any of the other subgroup, any of the other secondary outcomes, and no differences in any of the pre-specified subgroups. What about other interventions? The statins have been studied, and there's data suggesting that statins are associated with decreased risk. Interestingly, that risk is attenuated when you look at or that benefit is attenuated when you look at the patients who you would want to use it in, which are the patients who have chronic kidney disease. I'd also point out that patients undergoing angiographic procedure probably have another indication for being on statins other than prevention of AKI, so that I'm not sure that this is necessarily the right intervention. Let me talk about some of the other approaches taken. Remote ischemic preconditioning. The idea here is that creating ischemia elsewhere in an extremity, either by blowing up a blood pressure cuff or blowing up a balloon in a major artery, causing transient limb ischemia, results in the release of danger-associated molecules, which then are sensed by the kidney, puts the kidney into transient cell cycle arrest, and if the cells are in transient cell cycle arrest, they're protected from ischemic or nephrotoxic insults. And there are data suggesting that remote ischemic preconditioning may be beneficial in patients undergoing cardiac cath. Now, I interpret this with some caution, since other studies looking at remote ischemic preconditioning in other settings, particularly cardiac surgery, have not been as beneficial, and I think this is an area that requires further investigation. Hemodialysis and hemofiltration have been looked at with the thought that if we can remove the contrast before it causes toxicity to the kidney, it could be a good preventative therapy. Multiple studies have been done. Dina Cruz has published a series of meta-analyses, incrementally adding additional studies each time. This is her most recent meta-analysis from 6 years ago. The top panel is intermittent hemodialysis, where not only is there no benefit, the trend appears to be towards harm. And you wouldn't expect that prophylactic hemodialysis would provide a benefit, since it would take between 8 and 12 hours of hemodialysis to remove 90% of the contrast load. So it's not going to provide a benefit in terms of contrast removal in the timely fashion that you need. I find the data on hemofiltration intriguing. Partially intriguing in that this made it past reviewers at the New England Journal of Medicine. So in this study from Italy, patients were randomized either to continuous therapy, started 12 hours pre-procedure, or to routine care, and the primary endpoint was change in serum creatinine. The problem is that the intervention lowers serum creatinine. So the intervention is directly altering the marker of the outcome. So you can see in the continuous therapy arm the reduction in serum creatinine from baseline to day 1. And it looks to me like the increase after here are pretty much the same. How this got past the reviewers baffles me. And they then published another study in the American Journal of Medicine where they looked at starting the continuous therapy 12 hours pre-procedure or starting it immediately post-procedure. And what they demonstrated was starting it pre-procedure had a greater benefit. Again, greater lowering of serum creatinine. It's actually not providing a clinically meaningful benefit. So there's an issue there. What about avoidance of nephrotoxins? Certainly we know that nonsteroidals are of benefit. They should be stopped because they're associated with hazard. Big question that comes up is what about RAAS blockers, ACE inhibitors, and ARBs? And the data here is actually very confusing. There's actually a study that shows that acute administration of captopril is associated with a renoprotective effect. Most of the studies are more like this. So they're relatively small, underpowered studies. They've been randomized. Here's one of discontinuation. So 220 patients randomized to either continuation or discontinuation, and they have data on 63 patients who were RAAS blockade naive. You can see that, in fact, the patients who had discontinuation had a lower rate of AKI. This was not statistically significant. It's a very underpowered study. So it doesn't surprise me that it's not statistically significant. But what happens when you put a patient on an ACE or an ARB? You see a hemodynamic effect with an increase in serum creatinine, so a decrease in GFR. What happens when you acutely discontinue a RAAS blocker? The exact opposite. So we have an issue here. If this is the distribution of the change in serum creatinine after contrast exposure, so you have some patients that it goes up, smaller number of patients that it goes down, the median is a modest increase in serum creatinine, and we call some arbitrary increase in serum creatinine AKI, looking at this as a categorical outcome. And then we give an intervention that systematically changes serum creatinine. We see a decreased rate of AKI. But that doesn't necessarily mean we've protected the kidney. So, discontinuing an ACE or an ARB causes this pattern. Hemofiltration causes this pattern. Unfortunately, a lot of our other interventions also do this. So volume expansion lowers serum creatinine. Bicarbonate may have a smaller volume of distribution than saline, so an equal volume may have a greater effect on volume. N-Acetylcysteine, depending upon the assay for creatinine, may interfere, and I'll show you that data. Statin exposure. I bet no one in this room knows that in the original registration data for Rosuvastatin to the FDA, they demonstrated that there was an acute increase in eGFR associated with Rosuvastatin exposure. That means there was an acute decrease in serum creatinine. So this is from a meta-analysis done by investigators from the NIH looking at N-Acetylcysteine, and all of the studies that were of benefit were associated with a fall in serum creatinine, as was seen in the original study. And as I said, if you're using a colorimetric Jaffe reaction, some of the assays have interference. So where does that leave us in terms of what we should do? I think that we have a great deal of uncertainty. So in a very few moments, let me talk about the longer-term outcomes after an episode of contrast-associated AKI. It's been associated with many adverse outcomes. Even after adjusting for risk factors, we see this. So this goes back to the original risk score that I showed you, that not only is calibrated for nephropathy, but is also calibrated for risk of death. And when you look at, when you adjust based on the that risk score, and then look at outcomes in patients with and without AKI, there is a 22-fold increased risk of death in patients who have AKI versus those who don't. And we also see increased risks of MI, vessel reocclusion, and other adverse events. This has been seen in other studies, so this is an analysis by Matt James from the University of Alberta. Mortality, end-stage renal disease, heart failure, hospitalization, acute renal failure, hospitalization, and in each of these, no AKI, stage 1 or stage 2 to 3 AKI. So where does that leave us in terms of the model? Okay, so we have AKI, and AKI is associated with the development of adverse outcomes. The problem is that the risk factors for AKI are also the risk factors for these outcomes. And although we hope that our interventions decrease the adverse outcomes, we have the problem that there are intervening events that may also cause the outcomes we're looking at, or may also cause AKI. So it wouldn't surprise you to learn that in a patient who has a cardiac cath, that there's an increased probability that they're going to be in the OR over the next 30 days on bypass. So what did we see in PRESERVE? Of the 4,993 patients, 445 had AKI, 45-48 did not. Of the patients who had AKI, 11.9% developed the 90-day outcome, versus only 3.8% in the patients who didn't. But if you look at the absolute numbers, there were more patients who had the 90-day outcome who never had AKI. In fact, fewer than a quarter of the patients who had the 90-day outcome had previously had an episode of AKI. So trying to tease all of this out is extraordinarily difficult. So what should we do for the patient who's in front of us? We need to identify the high-risk patients. We need to use the lowest risk contrast agent. I would recommend volume expanding with isotonic crystalloid, and I see no benefit to bicarbonate. I don't use N-Acetylcysteine. I think the role of statins is uncertain, but most of these patients should be on statins anyway. I discontinue nonsteroidals and other nephrotoxic drugs. I didn't talk about the role of chronic diuretics, but there's no evidence that discontinuing chronic diuretics is beneficial, although I don't give acute diuretics. And I actually continue RAAS blockade in patients, although I consider that to be an area of continued controversy. So I thank you for your attention. Hopefully we have a few moments for questions.
Thank you very much. I'll ask you to call on the audience. We have time for maybe one or two quick questions, quick answers.
Sure.
Just your thoughts on CT angiography and the risks involved there. Coronary angiography is compelling, you got to go. CT angiography, maybe we're doing a little more than we need to. Are there opportunities there to prevent the contrast going in the first place?
So the question was to comment on the role of CT angiography. So again, with CT angiography, there's this whole question that the Mayo Clinic group has raised about risks with CT scans. I think that there is a risk of contrast-associated AKI with CT angiography. You are giving a larger dye load than you might have to give with a regular angiogram. And we have alternative imaging techniques. So while I would not do MR angiography using gadolinium, I think the quality as the magnet strengths get better and better of using things like time of flight or using alternative contrast agents for MR, such as ferric agents. There are some iron-based contrast agents that have been used, provides a good alternative, and it would be the approach that I would go rather than in a particularly high-risk patient of using iodinated contrast.
We're going to have to close there. I want to thank Dr. Hertz-Tang for identifying identifying Dr. Palevsky and to Dr. Palevsky for an outstanding Grand Rounds. Thank you.